All right, here we are back with chapter 34 and part 2 of face and neck trauma. So let's roll on through this and we'll get this chapter buttoned up pretty quick. So let's talk about some trauma or injuries to the ears that we might have to deal with. Lacerations, avulsions, contusions to the external ear can result from blunt or penetrating trauma, either one. The pinna doesn't have a great blood supply, so it often doesn't heal really well, and the poor healing is often made worse whenever there's some kind of an infection involved. Foreign bodies are the most common problem in children. While most of them are solid, organic matter can also be found in the ear canal. When assessing the patient, you should try to figure out what the object is and how quickly it needs to be treated. So you kind of got to determine if is it an urgent thing or can you kind of wait a little bit. Visual clues like bleeding, redness, inflammation, or signs of infection can help with your assessment along the way of that. Any object causing serious symptoms, discomfort, or that could cause harm if left untreated should clearly be considered an emergency. A ruptured eardrum can happen from a direct blow, foreign bodies poked in the ear, or pressure-related issues like blasts or diving injuries. Signs and symptoms are going to include hearing loss and blood draining from the ear. In most cases, the eardrum will heal just fine on its own, and it's not typically an emergency. So when we're assessing ear injuries, the first priority is going to be sure to take care of and make sure the airway is open and the patient is breathing adequately, just like we do with every patient. If the mechanism of injury suggests a potential spinal injury, be sure to use full spinal motion restriction precautions or as what's defined by your local protocol. If manual direct pressure doesn't control the bleeding, place a soft padded dressing between the ear and the scalp, and then apply a roller bandage to hold that dressing securely in place. You can also use an ice pack to help reduce swelling and pain, and it might actually help to slow down some of the bleeding as well. If the outside of the ear is partially avulsed, gently put it back into position, and you then use a bandage with some padding that's been slightly moistened, because we don't want that piece to dry out, with some normal saline, then kind of secure that to the ear. If it's completely avulsed, try to find the avulsed part, of course, so that it can be hopefully reattached. To preserve that part, wrap it in a saline moistened gauze and place it in a plastic bag, and then put the bag on ice if you have that opportunity. Of course, you don't want to put the avulsed part directly on the ice. It needs to be protected from the ice because the ice can actually damage it. If you're using an ice pack, remember you want to shield that part as well. So you don't want to allow that part to get burned by the ice, because the ice can actually burn it. It can cause damage that way. If you see blood or cerebrospinal fluid draining from the ear, apply a loose dressing. But the goal here is not to stop the flow of the blood, or the fluid coming out of the ear. We just want to collect it. You should also assess the patient for signs of a basal skull fracture whenever you see that bleeding coming from the ear. Don't remove an impaled object. Instead, stabilize it in place and cover the ear to prevent it from moving or to minimize contamination. It's generally not a good idea to probe for foreign bodies, although an otoscope can be used if your protocols allow it and you've been trained to use it. Make sure you perform a careful assessment to detect and rule out more serious injuries before providing any specific care. Now let's move on to the mouth. Oral and dental injuries are often associated with facial trauma, kind of goes hand in hand. The main risks are going to include airway compromise from bleeding in the mouth and throat, or a blockage caused by displaced dental appliance or a tooth that's been avulsed or fractured and then inhaled. Those are usually the bigger problems that we're going to deal with. Soft tissue injuries like lacerations, avulsions, are dangerous because they can cause severe bleeding inside the mouth, which could then compromise the patient's airway. When assessing any patient with facial trauma, it's really important to do a careful evaluation of their mouth and look closely so you know exactly what you're dealing with. Fractured or avulsed teeth and cuts to the tongue can cause a lot of bleeding that can, compromise the upper airway, and they can be tricky to control that bleeding as well. When a patient is responsive and has severe bleeding in their mouth, they're often unable to speak unless they're leaning forward. This position helps the blood drain from the mouth, and it is clearly the ideal position for them to be in. Patients may swallow blood from the mouth lacerations, which will significantly increase the risk of vomiting and ultimately the possibility of aspiration. Objects that are impaled in or through the soft tissue of the mouth can cause a lot of bleeding and can also increase the risk of vomiting and aspiration. For instance, this image that we've got here, if there's no airway compromise, we're going to leave that thing right where it's at, because if we take that out, the bleeding could get a whole lot worse. And then, we could actually make things worse by messing with it. Dental injuries can be part of severe facial trauma, or they can happen on their own. You should always check the patient's mouth after they have had any kind of facial injury. If a patient is unconscious and has missing teeth you should assume that the teeth are in the airway until you can prove otherwise. They may have swallowed them, but you need to assume that they're probably in the airway. In that situation, you may need to use a laryngoscope for a direct look to confirm whether or not they're there, and that's all going to depend on if they're having any difficulties breathing or that kind of thing, and whether or not you decide you need to take better control of the airway. So when we're managing these types of injuries, the first priority is going to be to make sure that the airway stays open and they're breathing adequately. You may need to suction the oropharynx or remove any fractured tooth fragments as needed. Apply spinal motion restriction precautions as dictated by the mechanism of injury. If there's a lot of oral bleeding and the patient can't protect their own airway, you may need to perform a pharmacological assisted intubation, or an RSI, rapid sequence intubation, where you knock them down and you take total control of their airway. Realize though that this is a pretty hefty step to take, and you need to make sure that you're ready to take that on. So impaled objects in the soft tissue of the mouth should be stabilized in place unless they're interfering with the patient's ability to breathe or your ability to manage their airway. Your medical control may tell you to reimplant an avulsed tooth by placing it back in its socket and having the patient hold it in place by biting down. Many teeth can be reimplanted that way, but if you can't reimplant it in the field, follow the guidelines from the International Association of Dental Traumatology to manage that tooth and transport it with you to the hospital, because it may be able to be reimplanted there. If a patient is unstable, their airway, spinal precautions, and getting them to the hospital, make sure you get them managed well and take care of that stuff quickly. Those are the most important things to focus on. Dental problems will be addressed later. They're not a huge priority, but if you can preserve the teeth, then ideally you do that. But if it's life over teeth, we're going to choose life over teeth. All right, so let's take a look at the front part of the neck and some of the things that we might have to deal with. The neck injuries are classified by zones, and we can see in this image here what we're talking about. So zone 1, it can extend from the chest and may be hard to find during a physical exam. They also have the highest mortality rate. Ironically enough, you would think that the higher up zone, like maybe zone 2 or 3 would be worse, but the zone 1 injuries have the highest mortality rate. Zone 2 are the most common, usually the easiest to spot, and have a much lower mortality rate, which seems a bit ironic. And zone 3 are often difficult for surgeons to access and repair because of all the structures that enter at the base of the skull in that particular area. Makes it really, really difficult for those injuries in those particular areas to be ultimately managed well. When dealing with soft tissue injuries of the neck, always be alert for potential cervical spine injury and airway compromise. Common causes of blunt trauma to the neck include motor vehicle crashes, direct trauma, and even hangings. Blunt trauma often results in swelling and edema, injury to the various structures of the neck, and injury to the cervical spine. You should be prepared to aggressively manage these blunt injuries and take strong control of the airway. Penetrating neck trauma is often caused by gunshot wounds, stabbings, and impaled objects. The main dangers from penetrating trauma are massive bleeding from damage to major blood vessels and the airway compromise from swelling or direct damage to the airway structures. Open neck injuries are at risk of air embolisms because exposed jugular veins can actually suck air into them, which can then ultimately block blood flow. If you see this, you need to act immediately and seal that wound with an occlusive dressing so that it can no longer suck air into it. Be careful not to constrict the vessels or other structures of the neck, and always watch for swelling and expanding hematomas. Impaled objects in the neck can cause several life-threatening problems, so you should definitely not remove them. Instead, stabilize and protect the object from any movement. The only time you should remove an impaled object is if it's obstructing the airway or making it impossible for you to manage the airway. In that extreme case, an emergency cricothyrotomy might be necessary. It's interesting, you look at this picture where that knife stab is up the neck. Notice that there looks like maybe some bruising around the right eye as well. I don't know if that's pre-stabbing or post-stabbing or partly because of the knife. I mean, can you imagine if that knife is that long that it's extended that far, that it would cause bruising around the eye? So injuries to these structures can happen if the front of the neck is crushed against, where we're talking about the larynx, trachea, and esophagus. Sorry, I guess I thought you were reading my mind. So anytime we have injuries to these structures, or injuries to the front of the neck, and the front of the neck is crushed against the cervical spine, we can wind up damaging or injuring any one of these, the larynx, trachea, or esophagus. These injuries may not be obvious at first, so you need to maintain a high index of suspicion with certain types of injuries that may result in that. Significant injuries to the larynx or trachea are an immediate risk for airway compromise, and esophageal perforation can cause mediastinitis, which is an inflammation of the mediastinum that often results from the stomach contents leaking into the chest cavity. This has a very high mortality rate, so we need to make sure that we recognize this and get them to the hospital for emergency surgery as quickly as possible. Fractures to the maxillae and the face can make bag mask ventilation difficult, and endotracheal intubation may be challenging or even impossible. A surgical or needle crack might be the only way to establish a good patent airway. Common signs of injury to the front of the neck include bruising, redness of the skin, and even some tenderness when you touch a particular area. You should also note the mechanism of injury and keep a high index of suspicion for more serious problems to develop along the way. If the patient is unresponsive, manually stabilize their head in a neutral inline position and open the airway using the jaw thrust maneuver. Be ready to use suction as needed. Assess the airway. If breathing is adequate, you can continue with your assessment. If it's partially adequate but the patient's in some distress, apply a non-rebreather mask with 15 liters of oxygen. If it's inadequate, assist their breathing with bag mask ventilation and 100% oxygen, and begin to look for ways that you can provide a more secure airway before you move on with your assessment. Always treat the injuries that pose the most immediate threat to the patient's life first. After that, then we're going to move on with the rapid exam to find and treat any other injuries. Control bleeding from an open neck wound. Immediately cover it with an occlusive dressing. You can use capnography electrodes as a quick and effective way to seal a small wound. After applying the occlusive dressing, use a bulky dressing and apply direct pressure over the wound. Secure the pressure dressing by wrapping roller gauze loosely around the neck and then firmly through the armpit. Now, realize that we don't want this to, occlude the airway or anything like that. So you're going to need to reassess that bandage around the neck frequently to make sure that it's not getting too constrictive. And then you're going to monitor the patient's pulse for reflex bradycardia, which indicates that excessive pressure on the carotid artery has stimulated the parasympathetic nervous system response. If they show signs of shock, give them oxygen and keep their SATs around 94. Also control any external bleeding, keep the patient warm, and establish vascular access with at least one 18-gauge IV. Infuse an isotonic crystalloid solution as needed, and aim to maintain a systolic blood pressure between 80 and 90 millimeters of mercury. Patients with serious laryngeal trauma may need surgical or percutaneous airway. Endotracheal intubation can be dangerous because the tube might actually pass through the defect in the laryngeal or tracheal wall. Signs of this serious complication include increased swelling of the neck, worsening subcutaneous emphysema throughout the chest during and after ventilations. In an open tracheal wound, you might be able to pass a cuffed ET tube through the wound and establish an open airway. Be cautious doing this, as the trachea could be perforated both in the front and the back, so you may just pass straight through. Always use multiple techniques to confirm that the ET tube is in the correct position. All right, so let's take a look at the spine. The neck can be injured without any damage to the bones. A sprain is a stretching or tearing of the ligaments, while a strain is a stretching or tearing of the muscle or tendon. In these cases, you should take cervical precautions. And you can kind of see here, this is a pretty significant neck injury. Patients with suspected spinal trauma should be transported to the emergency department for x-rays and other radiologic studies. You should also visually inspect the patient for any signs of soft tissue injury. If the patient is symptomatic to pain, you'll need to maintain a spinal mobilization restriction on them. If the mechanism of injury requires you to follow spinal clearance protocol and your exam causes the patient pain or resistance, you should immediately stop the exam. In this case, you must maintain spinal motion restriction and transport the patient to the emergency department for further evaluation, and you should not evaluate them any further. Anyone who reports neck pain after an injury should be evaluated in the emergency department. Be sure to address any issues with their airway, ventilation, and oxygenation as we're managing them. Ensure that there's no major circulatory compromise, and prevent any further injury by using motion restriction. If your exam doesn't reveal any obvious mechanism of injury, treat the patient as you would any other muscular strain or with rest, ice, and elevation. A soft collar can be used to support the head and strained muscles. Even if there's no obvious case or obvious cause, any patient with neck pain should still be evaluated for those hidden injuries that we can't see. All right, and last, we're going to wrap this up with injury prevention. Many improvements have been made to protect the face and neck from injury. To prevent injuries from high-risk activities, people should use helmets, face shields, mouth guards, and safety glasses. All of these things are pretty commonplace. It makes me think back to the early days of football when they just wore this leather helmet and ran around bashing into each other, and then the little one bar, the plastic helmets that had the little one bar face guard and all those kinds of things, and we still had all kinds of injuries. Why it took so long for us to eventually reach that point. Early on, I realized we didn't have plastics and all that, but a leather helmet to protect your head, it just kind of boggles the mind nowadays. But now we have a multitude of things for our safety to protect the head, and even NASCAR tethers the helmet to the seat so that it can only travel so far before it is stopped to help prevent some of the injuries that have been associated with accidents at high speed in NASCAR events. Advances in motor vehicle safety include better occupant safety restraints, airbags, and improvements to headrests. We've seen this picture that looks like the whole inside of the car blows up into an airbag. It used to be it was just the airbag in front. We started out with just an airbag and a steering wheel, and then we started putting them on the passenger side. Then we started putting them on, the side curtain windows, and now they pop out of the headrests on either side of the patient. in the back seats and the front seats and all that kind of thing. Cars are no longer designed to be salvageable after an accident. The car's designed to protect the people inside of it and throw the car away if we have to afterwards. Early automotive designs, the thought was, we're going to make these things tough so if they're in an accident, they can still be used afterwards. Today's cars are not that way. We'll just throw them away. All right, so that's it for trauma to the head and neck, chapter 34. Quick chapter, not too bad, pretty easy to understand information, so you guys should do well. All right, see you back at the next chapter.